So welcome everyone to our webinar on the 2024 US MEC update. I'm Paulina, I'm the co-founder of Dama Health, and I'll be your host for today. So just before we dive in, just a quick update in terms of how the session will run. So it's going to last around 45 minutes. We'll have a dedicated Q&A session at the end, so around last 15 minutes of the session, where Aaron will be answering the questions on the US MEC and the presentation. So please submit any questions in the Q&A feature. And if there's any technical issues, please use the chat and we'll try to manage if there's any technical issues. And we are recording this webinar as well, so it's going to be available later for whoever registered. So in terms of our agenda, we'll start with the presentation on significant changes in the guidelines and clinical implications. Then I'll just spend a quick few minutes explaining how Dama digital platform supports implementation of these latest guidelines. And then we'll have this Q&A session, as I mentioned, with our experts. So speaking of our experts, it's my pleasure to introduce our speaker for today, Dr. Aaron Lazorwitz, who is a founding member of the Dama Health team. Dr. Lazorwitz is an assistant professor at Yale University School of Medicine. He is a board-certified OBGYN and associate program director for Complex Family Planning Fellowship. Dr. Lazorwitz has been pioneering the research on contraception pharmacogenetics, and he's a key opinion leader when it comes to understanding the role of genetics and hormone response variability. So without further ado, I'll hand over to Dr. Lazorwitz.
Thank you so much, Paulina, and thank you everybody for attending today and for those listening afterwards. I'm going to start the presentation here. Perfect. All right. So we're going to be talking about the update to the CDC MEC, and this is an informational webinar about the changes and kind of how they can affect your clinical practice. And like Paulina mentioned, please feel free to put questions in the Q&A or in the chat, depending on how, if it's not working, and we'll have time at the end to go through all your questions. So just a quick disclosure, I was at the January meeting for the CDC to talk about some of these changes, and so I have kind of firsthand knowledge of the discussions that went into these changes. This is all public, though. If you look at the CDC MEC update, it lists everybody who was in attendance, and that's what goes into these updates is a lot of opinion, from experts in the field, from across the field, which is great. So, quick review. What is the CDC MEC? It's the medical eligibility criteria for contraceptive use. This is put up by the CDC to give recommendations on contraceptive use with medical conditions or other medications, and it gives a category of 1 to 4. 1 being a condition which there's no restriction, no concerns. 2, where typically the benefits are going to outweigh the risks of that method and that condition. 3 is where the risks start to outweigh the benefits, but you could still consider use in some circumstances. And then 4 is really where there's unacceptable health risks. And so this is just, classification that the CDC uses for these recommendations. And for the 2024 update, this all started back years ago. So there's been meetings with subject matter experts for years and systematic reviews in the literature done by the CDC that are now publishing those. And these typically happen every 5 years, but as most of you know, the last update was 2016. Unfortunately, COVID significantly delayed this update. And so that's why it's been now, 8 years since the last update. So hopefully the CDC plans to get back on schedule, but you never know with these kind of things and you never know what's going to happen. But fortunately, some things have changed for good. And so we're going to talk about some of those most significant changes. We're going to talk about depo and venous thromboembolism risks, the new stratification for post-abortion, obesity, and combined hormonal methods, surgery of prolonged immobilization, chronic kidney disease, lupus, high risk for HIV infection, cirrhosis and liver tumors, sickle cell disease, and finally, current DVT, PE on therapeutic anticoagulation. Looks like a lot, but fortunately, a lot of these changes are pretty simple and straightforward, and so there's some common themes that came out with this update. And, I recommend if you've got some free time and you're looking for a very interesting read, there is the supplementary appendix that came out with this update that really goes through all of the data that was reviewed for these updates. So the CDC did a great job putting together all the studies they were evaluated and where these recommendations actually came from. So biggest thing is a lot of changes for depo. Specific categories that changed. So for breastfeeding, 30 to 42 days postpartum, with other risk factors for VTE went from a category 1 previously now to a category 2. Postpartum, non-breastfeeding, less than 21 days postpartum, or 21 to 42 days with other risk factors for VTE also went from a 1 to a 2. History of DVT-PE, higher risk for recurrent DVT-PE went from a 2 to a 3. Thrombophilia went from a 2 to a 3. Superficial venous thrombosis went from 1 to a 2. Complicated valvular heart disease went from a 1 to a 2. Peripartum cardiomyopathy went from 1 to 2 and a 2 to 3. So as you can see, these all got worse, right? Common theme. They all got worse for conditions we know could be associated with an increased risk for VTE. So what is the explanation that the CDC has? It says limited evidence suggests that depot use might further elevate the risk for VTE among postpartum women. Talks about depot associated with a higher risk of venous thrombosis compared with non-use, might elevate the risk for individuals with a history of DVT-PE, and same thing with those with factor V Leiden. So common theme is it's saying patients who are at higher risk for a DVT or PE, a venous thrombosis, depot may exacerbate that risk. Apologies. And so, initially, kind of why was depot not given these higher recommendations, previously was because results from studies varied quite a bit. So initially, it showed that maybe there was an association between depot use and higher risk of venous thrombosis, but it wasn't consistent, although a pattern started to emerge. There were a couple studies, one being the multiple environmental and genetic assessment study that found depot had a 3.6-fold increased risk for VTE compared to non-users. What was good about that study is they also found levonorgestrel IUD users did not have an increased risk of blood clot, so good control because we know the levonorgestrel IUD does not cause increased blood clot risk. There was a case control study from Sweden where depot had associated with an odds ratio of 2.2 for venous thromboembolism. In that study, estrogen-containing combined hormonal methods had an odds ratio of 5.3, so also increased. So again, a positive control from that study. And then there was a commercial claims database of postpartum women that also found immediate depot had a increased incident ratio of 1.94 for VTE. So kind of a common theme, but a lot of these studies were older, kind of the data wasn't as clean as people had hoped. And a lot of these are non-US populations. So the CDC really prefers data from US populations because that's who the recommendation is being created for, right? And it's also hard because VTEs are rare. So it's harder to study. But there was a study published in 2022 by Cochran et al. That was a nested matched case control study using the IBM Market Scan database. So this is a nationwide sample of private insurance claims across the US. So these are all US patients. And actually, they had 21,000 women with a venous thromboembolism to look at, and then 107,000 controls for comparison. So very large numbers of patients to actually look at. And they found that depot use compared to non-use had an adjusted odds ratio of 2.37. So the odds of getting a VTE with depot were over twice that of non-users, with all other progestin-only contraceptive methods not associated with VTE. So good controls again, IUDs, implants, progestin-only pills, they were fine. What was interesting in that study, they also found oral medroxyprogesterone acetate. So the oral form of the progestin used in depot also had an increased odds ratio for VTE. And the norethindrone acetate in the 5 milligram dose that's given for control of bleeding, not the contraceptive dose, had an increased odds ratio for VTE. So, but focusing on the depot, is this real? That's always the question. Why? Why would it be doing this? And there is actually a realistic physiological plausibility for that because not all progestins are equal. They're all slightly different. So depot actually has some glucocorticoid activity. And so you've got depot here on the top and then cortisol to the right. There's some similarities in the structure. There's some crossover activity. And this crossover for glucocorticoid is unique to medroxyprogesterone acetate. Other progestins don't have this activity. And we know glucocorticoid activity upregulates thrombin receptor expression, and that can lead to a dose-dependent increase in VTE risk. We see this with glucocorticoid use, and now we're starting to see it with depot, with medroxyprogesterone acetate use. So this is real. This is a real pattern that has really started to emerge. And at the meeting, all of us who knew about this newer data were saying we need to finally say, hey, depot can actually increase the risk. It's not as bad as estrogen-containing contraception, but there is a real risk here, and the recommendations need to change. And so as the CDC has changed their recommendation, it's also time to start changing practice. Really got to start to consider patients who are at high risk for VTE, history of VTE, thrombophilias, multiple risk factors, probably shouldn't consider depot for those patients. Should probably consider other contraceptive methods just because this risk is real. And so that's probably the biggest change that came in the whole update, is all these changes to the recommendations for Depo for all the potential factors that increase the risk of VTE. So we'll kind of move on to some of the other changes, which are a little bit more straightforward. So post-abortion was stratified into new categories. It was now stratified into procedural or surgical, medication, and spontaneous abortion with no intervention. So it changed it, but really the only change that happened was Depo was changed to a 1/2 for medication abortion, with a clarification that concurrent administration of Depo with mifepristone might slightly decrease medication abortion effectiveness and increase risk for ongoing pregnancy. So what is this from? This is actually some good data that's been around for a bit. There was a randomized control trial of women undergoing medication abortion who wanted Depo. They were randomized either to receive Depo at the same time they got the mifepristone, or they got Depo after they completed their abortion. What they found was a higher ongoing pregnancy rate in the patients who got the quick start, got the Depo with the mifepristone, 3.6% versus 0.9%. Now, the need for surgery for intervention was actually not significantly different between the two groups. It was 6.4% versus 5.3%. And the thought was also, oh, if you do a quick start, they'll have lower pregnancy rates at 6 months because they'll have gotten their method, it's on board. But actually, the pregnancy rates were pretty equivocal, 2.3% versus 3.2%. So really, giving Depo at the same time as mifepristone does increase the risk of an ongoing pregnancy for medication abortion. But the quick start group did have higher patient satisfaction, right? Because they got their method when they wanted it. So this is a great opportunity for shared decision making with your patients. That, if a patient's coming in for a medication abortion, if that patient's able to do their follow-up and come in, probably best to give the Depo at the follow-up visit, right? To give it at a different time, just to keep that risk of ongoing pregnancy low. But if that's the patient's only opportunity to get contraception and they really want Depo, then you could make a good argument that the benefits outweigh the risks, right? That giving the Depo, as long as the patient has full awareness of what symptoms to watch out for a medication abortion failure, is completely reasonable. And it's not clinically wrong at all. That's why it's just a recommendation too, right? That you can definitely consider it, just counsel on a slightly increased failure risk. And so next change was in obesity, which was a change for combined hormonal contraceptive methods, where obesity itself, BMI greater than 30, went from a 1 to a 2. So it became higher risk. And the explanation here is that risk for thrombosis increases with multiple risk factors, as we know, with many examples given here. And just basically saying, look, when a person has multiple risk factors, you really got to be considerate of then giving a combined hormonal contraceptive method with estrogen is going to also increase their risk of venous thrombosis. And so it's not just a simple addition, though. You can't just be, 1 + 1 of these VT risk factors means you can't use combined hormonal contraceptive methods. But the CDC just wants us all to be aware, as we should, that each of these is an independent risk factor for VTE and needs to be considered. And so obesity needs to be considered on its own as a risk factor. And so if you have an older patient who's obese and, with later stage diabetes, probably not the best candidate for a combined hormonal method, but just something you need to keep in consideration, right? And so this came from a systematic review where combined oral contraceptive users with obesity have a relative risk of VTE about 5 to 8 times that of non-users with obesity. So it seems that the estrogen use exacerbates the risk from obesity itself, but caveat, very limited data on patients in the highest BMI categories. This is a chronic issue in the literature of that these patients are often not included in studies. And so we just lack data on the highest BMI categories. But definitely, again, ultimately just consider BMI as a VTE risk factor. When you're thinking about, is this patient a good candidate for a combined hormonal contraceptive method? Something that you should consider as a independent risk factor. And then surgery with prolonged immobilization, leave-in additional IUD was previously a category 2, now a category 1. Implant category 2, category 1, and progesterone pills category 2, now category 1. This is great. We've asked for this change for a while. There's no concern for increased VTE risk with these progesterone methods. The data supports that strongly. Surgery or prolonged immobilization, usually we're talking about an orthopedic surgery, right? So the patient's not going to be ambulating for a while. Basically saying these progesterone methods are completely safe. There's no concern for VTE. That's not a concern here. Depo remains a 2. right, for these patients, which is fair. Also something to consider is a VT risk, and combined hormonal contraceptive methods are a 4, which you should, because of their increased risk for VT, you should not give them estrogen in this situation. So this is a great, easy change. Chronic kidney disease is a whole new category that was added. So this was not a medical condition included before, but definitely should be included because these patients have some unique things to consider. So as you can kind of see here, we're really focusing on patients with chronic kidney disease that have complications. So current nephrotic syndrome, hemodialysis, peritoneal dialysis, with the big takeaway here being Depo category 3, combined hormonal methods category 4, and then for the progesterone-only pills, a special consideration for the drospirenone progesterone-only pills. All the other progesterone-only methods are 1s and 2s and are totally fine. But the other contraceptive methods are the ones we need to care about. And so the big thing is chronic kidney disease is also associated with increased risk of adverse health events as a result of pregnancy. So it's a box 3 category. Box 3 is all the medical conditions that can potentially get exacerbated by pregnancy. And so it's important to weigh those risks when considering contraceptive method risk as well. And then the clarification of the drospirenone-only pill. Why is that kind of called out? The CDC's never done that before. This is a unique situation where these patients are at risk for hyperkalemia and they have known hyperkalemia, then you should avoid a drospirenone progesterone pill because that could potentially worsen the hyperkalemia. If the patient doesn't have known hyperkalemia, consider checking a potassium level just during the first cycle of use for drospirenone progesterone pill, just to be sure. Where does that come from? Well, drospirenone is derived from spironolactone, and so it has some of the anti-mineralocorticoid properties of the parent compound that carries over. So there basically has potential for hyperkalemia that's about equivalent to a 25 milligram spironolactone dose. So pretty small dose of spironolactone, but it has some potential for hyperkalemia. In the pivotal drug trial, really the patients that developed hyperkalemia, it was mild at worst and then usually returned to normal. There were only 2 patients in that first trial, which was 0.2% of the total patient population, that discontinued the drug due to persistent potassium elevation. So it's extremely rare that hyperkalemia is an issue with the drospirenone-only pill, but it can occur. So these patients who are at higher risk for this, something to consider for sure. And definitely if they already have pre-existing hyperkalemia, I would not recommend using the drospirenone-only pill in those patients. For IUDs, completely safe, all 1s and 2s, no concerns here. There's no comparative studies though. There are some case reports, but case reports are not research. Really, they highlight very rare things that have happened. There actually, the case reports, one was a positive one with a levonorgestrel IUD user who had improved bleeding and anemia. So that as a consideration could have improved bleeding side effects with the levonorgestrel IUD. The other case reports showed a case of peritoneal allergic reaction, some peritonitis, and a TOA. But again, these are very rare and should not be used to guide clinical practice. Ultimately, the IUDs are safe. There's no increased risks for use, or the benefits outweigh the risk for these patients. For the progesterone contraceptive methods, Depo's a 3, implants, non-drospirenone pops are a 2. No direct evidence was identified. Really, we lack data on these patients, but we know chronic kidney disease with nephrotic syndrome or dialysis has an increased risk for VTE. Depo may exacerbate that risk. So same as everything else we talked about, very much probably avoid Depo in these patients. There's also the patients with severe chronic kidney disease have a higher prevalence of fracture. There's no direct evidence on this, but we know Depo can affect bone mineralization. So it's unknown if Depo could exacerbate that risk. So another reason to probably avoid Depo medroxyprogesterone for these patients. And then finally, for estrogen-containing contraception, category 4, right? There's no direct evidence, but it's, with the potential VTE risk, you should not give these patients estrogen. That's just going to increase their VTE risk even higher. Not a good idea. Strongly consider other alternatives. And so, that's chronic kidney disease. For lupus, there was kind of a similar change to what we saw with surgery, with immobilization, in that lupus with positive antiphospholipid antibodies, levonorgestrel IUD went from a 3 to a 2, the implant went from a 3 to a 2, and the progesterone pills went from a 3 to a 2, because there's no evidence that progesterone contraceptive use can cause increased VTE, right? And that's the concern with lupus with antiphospholipid antibodies, right? This again has been something we've been, in clinical practice, I've been giving these patients these methods for a long time because we know the progesterone contraceptive methods do not increase the risk of VTE. And so, even the highest risk patients with lupus for VTE, there's no concern giving them a progesterone-only contraceptive method. For high risk for HIV infection, they changed the IUD initiations from 2 to 1. And this comes from a high quality evidence from a randomized controlled trial, addition to some low quality evidence, but the high quality evidence was new, that there's no increased risk for HIV acquisition with copper IUD use. There's no studies with levodopa IUDs, but you can translate that data over to pretty much all IUDs. This has needed to be changed for a while. This has always been a very theoretical risk. It's something a lot of us in the field have disagreed with for a while. This came from what's called the ECHO trial that got published in 2019. This was a pivotal trial that compared HIV incidence rates among women using Depo, levodopa implants, and copper IUDs in 4 African countries. It was over 7,000 women that were randomized. They were all HIV seronegative and seeking contraception and had follow-up every 3 months for 18 months to check for seroconversion. And basically, there were no differences in HIV acquisition between the groups. So this study really showed that these contraceptive methods do not increase the risk of HIV acquisition. They had high follow-up rate, high contraceptive continuation rates. It was an excellent pivotal study that was done. Strong data supporting safety for these methods. And so moving on, cirrhosis and liver tumors, just a couple changes for decompensated cirrhosis. The levodopa IUD, the implant, and POPs went from 3 to 2. Again, very similar to lupus. Hepatocellular adenoma, IUD, implant, POPs, 3 to 2. Again, no direct evidence here, but this is based on our understanding of how these progesterone contraceptive methods work. There is a caveat that the hepatic metabolism could be changed, so it could lead to increased progestin levels, which could theoretically lead to increased progestin-related side effects, but we really have no data to support that. No one's really evaluated that. And so this hepatotoxicity might be less tolerated in patients with existing liver dysfunction, but there's no significant health risk is what it comes down to. And then we know hepatocellular adenomas generally regress or remain stable during progestin use. And so the important thing also is decompensated cirrhosis is a severe life-threatening medical condition. So you're almost never going to be in a situation where you're giving a patient with decompensated cirrhosis contraception. They're often going to be admitted to an ICU level of care. They'll likely have impaired fertility already due to their health condition. And so for these patients, really contraception is the least of their concerns until they can be stabilized. And so it's not a super common situation that occurs. For hepatocellular adenomas, those are estrogen sensitive, so you definitely want to avoid estrogen-containing contraception, but really there's no concern for progesterone-like contraceptives, again, except for maybe Depo, right? But really the IUDs, the implants, and the POPs, not a concern. For sickle cell disease, Depo was changed from a category 1 previously to a category 2/3 now. And this should be assessed according to the severity of the condition and the risk for thrombosis. So, and then combined hormonal contraceptives similarly changed from a 2 to a 4. So this is all due to venous thrombosis risk, right? So persons with sickle cell disease are at higher risk for stroke and venous thrombosis. And so by age 30, up to 25% of patients with sickle cell disease will experience at least one VTE episode. So it's very common. And so Depo is probably not a great idea for high-risk patients, same as combined hormonal contraceptive methods. Not a great option for patients with sickle cell disease due to the VTE risk. And then current DVT-PE on anticoagulation. This is kind of an interesting change. If they're on therapeutic anticoagulation, combined hormonal contraceptive methods changed from a 4 to a 3. The caveat, the explanation being here that persons using anticoagulant therapy are at risk for gynecologic complications of therapy, like heavy bleeding. The anticoagulation can cause menstrual bleeding to become much worse, right? Or hemorrhagic ovarian cysts. And a combined hormonal method could be a benefit in treating those conditions, but you got to evaluate it on a case-by-case basis. The thought process being here is that if they're on therapeutic anticoagulation, giving them estrogen will not actually worsen their risk of VTE because they're already therapeutically prevented from recurrence of the VTE, of treating their DVT or the PE. Now, the caveat is that as soon as the patient discontinues a therapeutic dose, so even if they go to an intermediate dose or a prophylactic dose, then you really should not keep them on an estrogen-containing method. You have to transition them to a progestin-only or non-hormonal method, if acceptable for the patient. So this was an interesting discussion at the meeting with the hematologists who were like, if they're on therapeutic anticoagulation, there's nothing you can do to make it worse, right? They're already therapeutic anticoagulated. So definitely that's a safe situation. The careful thing is that as soon as they come off, you really have to take the estrogen away. You really shouldn't be. And then, what is intermediate dosing versus prophylactic dosing? They're like, therapeutic dosing is the only one that qualifies. So if you have a patient in this scenario, really talk with the hematologist about it, and come up together with a game plan of how long they're going to be therapeutically anticoagulated, and talk to the patient as well of, hey, we can put you on a combined pill if that's what they want for now, but we need a transition plan, right? That's the most important thing. So something interesting, but yeah, the biggest caveat, intermediate dosing does not count. So that's the biggest take home from this, is it has to be therapeutic dose. So and like we talked about, the fully anticoagulated, there's just no increased risk from the estrogen at that point. So I know it was kind of a whirlwind of information, but a lot of small changes, but some common themes, right? Other take home, the CDC MEC has an app that's free. It's fantastic. I have it on my phone. I have all my residents and my learners get it on their phone because it's a great resource, right? So, this is a lot of information to keep in your mind. And so it's always a great resource to look it up, and you can search by condition, you can search by method to remind yourself of what the new recommendations are. With the big takeaways being, Depo increases the risk of VTE. So patients who are at increased risk of VTE, we should probably avoid Depo for those patients. The new categories of chronic kidney disease and then sickle cell disease, the change for that one is that those are also associated with increased risk of VTE, and so should avoid Depo and combined hormonal contraceptive methods if possible. And ultimately, that's all the major updates in the CDC MEC. And we have time to go through Q&A at the end of the presentation, and then Paulina is going to do a short presentation about the Dama Health tool and how that's incorporating these updates.
Amazing. Thank you so much, Aaron. It's a good reminder about how not easy it is to prescribe contraception in a very medical and safe way. And it's very interesting that actually in some cases you have to involve other specialists, as you mentioned, like hematologists, oncologists. Yeah, thank you so much for this very in-depth. And I'm sure we will have a lot of questions at the end. So I'll just quickly go over what Dama Health is and how we support staying on top of these updates. So quickly, Dama Health is a company, a startup on a big vision to personalize prescribing and care in female health. And we created a digital health solution that acts as a companion for your visits to enhance personalized and patient-centered care. The solution basically works both as a patient decision aid and a patient and a clinical decision support tool as well. So the way it works that a few days before the visit, patient receives an invite to our platform and creates a secure account. Then they go through this comprehensive and dynamic assessment that asks all about their medical history, lifestyle, goals, their past experience of contraception. And we ensure all these medical conditions from MEC are covered in this assessment as well. We also ensure that the patients are asked questions about their lifestyle and goals, menstrual symptom control, discreetness, reproductive goals, so anything required to make that personalized decision for them. And as soon as they complete the assessment, they receive access to education that is actually tailored to their needs and their answers that prepares them for that visit with you. We then analyze all the answers, which add up to around 150 data points when you actually factor in all the conditions from MEC, including potential contraindications, medical risks, underlying conditions, as well as those lifestyle and preferences. And we rank contraception options accordingly. We do this by using our intelligent recommendation system that we designed with Aaron, that we created on these latest guidelines and evidence. So it's all up to date, and we make sure that we have those questions about kidney disease, and we factor all of that in as well. And then we package this into a summary report that the provider receives before the visit into their EMR. And the providers can use this to streamline the visit, streamline the history taking, and arrive at a shared decision with the patient. The goal of this solution is really to enhance that personalized and patient-centered care while making life easier for providers and streamlining the work. So by doing this upfront work and assessing patient needs and history and providing them with relevant education, we are hoping that this is making the visits more efficient and focused. And by automating the latest guidelines, just to make sure that nothing gets missed and we have all those latest changes factored in as well and just automated for you. We also assess patient symptoms, checking for any underlying conditions like PCOS and endometriosis, and we're factoring in that as well. As obviously for some condition, contraceptive, especially hormonal ones, can be actually indicated and not just medical safety and risks. So making sure we have enough time, please get in touch with us if you're interested. I'll put my email as well in the chat, but we'll pass it on to Aaron again to focus on the Q&A today.
Perfect. And looks like we've got a question. So question is, how do weight loss drugs affect the contraceptive choice in cardiovascular risk factors? So that's a fantastic question. So what's important to know about obesity drugs is there's different ones. So the most common being Ozempic, which is semaglutide. And then there's also liraglutide, which I forget the brand name of. And then there's tirzepatide, which is Wegovy, made by Eli Lilly. So what's important is the semaglutides, Ozempic, and the other forms do not affect contraception. They don't affect absorption. It's perfectly safe to use any form of contraception with them that the patient could otherwise use. The concern initially was they'd slow down gastric emptying. Could they affect oral methods? But there's good research that the semaglutides do not. What is important is that patients can get pregnant as they start to lose weight, right? As we all know, fertility is heavily affected by weight. And so as patients lose weight, their fertility returns. And, I'm sure many of you are as well. I'm starting to see a lot more patients come in with unintended pregnancies because of these medicines, because they're losing weight. And now they're pregnant, and these drugs are not recommended to be used during pregnancy because we have no safety data. So they have to stop the medicine. And so it's strongly recommended for patients to use contraception while on these medications to avoid unintended pregnancies. And in terms of cardiovascular risk factors, the risk factors should improve over the course of as they lose weight, right? But you still have to consider what conditions they have at the time of starting the medicine. So if they're currently hypertensive when they start the weight loss drug, you should follow the CDC MEC in terms of what, if combined hormonal contraceptive methods are contraindicated at that time, right? As they lose weight, these conditions will likely, hopefully improve, and they may no longer have that contraindication. But I generally treat them at the time as when they're starting the medicine in terms of what are the best recommended contraceptive methods for them. And then we can always readjust once they're getting more stable and they've had significant weight loss in the medicine. The one thing to keep in mind is tirzepatide, Wegovy, it has a drug label clarification that it can impair the absorption of oral contraceptive methods. And so it's recommended to use backup contraception for 4 weeks after starting the medicine and for any drug change in the drug dose, right? And so I can tell you that there's not a ton of data on this, but because that drug level contains it, generally I avoid oral contraceptive methods in these patients because of that concern, right? I don't want them to have an unintended pregnancy or a contraceptive failure due to that interaction. And it has something to do, tirzepatide is both a GLP-1 agonist antagonist. It's got multiple properties, so it's potentially got differential effects on gastric emptying more so, but we just need more data. We need more research on that to really answer that question, but that is the one you got to watch out for, that if they're on tirzepatide, they either, on a birth control pill, they need to use a backup method, or preferably probably switch to a different method while they're on the therapy. So.
Amazing. It's very fascinating, especially as we were seeing through our platform, there's so many more patients we're adding that they're using these medications, and we actually saw in real life the uptake as well and their concerns around weight loss medications.
Yeah. All right. And then next question, are there any medical conditions that increase risk factors for side effects? That's a great question, and something we really don't have great data on. Theoretically, there's always been the thought of, do patients with PCOS, right? Because they have a hyperandrogenic state, so they're at a higher risk for androgenic side effects with contraception. Unfortunately, we just don't have good data. We don't really know the medical conditions that could increase the risk factors for side effects with birth control. There are medications that can increase the metabolism of the drugs that are in birth control, but that has more to do with the efficacy of the contraceptive method. There are also drugs that reduce the metabolism of the birth control. So fluconazole, itraconazole, and ketoconazole are the big ones for that. Does that actually cause an increase in side effects due to higher levels of drugs from birth control? We don't know. No one's ever actually looked at that. So really, unfortunately, there's not much data at all on medical conditions that actually, definitively increase risk factors for side effects with any specific contraceptive method. And there's such wide variability in the experience of side effects that that's something we're trying to answer that hopefully genetics can help us figure that out. But right now, it's a multifactorial experience, and there probably are some conditions that influence side effects, and we just don't know yet exactly those relationships. But hopefully something, as we keep exploring this issue, and something that Dama Health really wants to figure out. And that's part of our goal as well.
Thank you, Aaron. Exactly. So it's a great question, and stay tuned. We are conducting research on both phenotypic and genetic factors that affect side effects, and we have some studies in the works and applying for further grants and publications coming along around this topic as well. So hopefully shining a bit more light on this question soon.
Yeah. Perfect. Next question is, how do you handle patients that are worried that hormonal methods will cause cancer? That's also a common issue that comes up, right? So there's a lot of misinformation out there about contraceptive methods and cancer risk. And so the best way that I handle that is just open and honest conversations with patients about what is their concern. Do they have a family member who has a specific cancer? What have they heard? And talking about both the potential cancer risks with specific methods, but also the cancer prevention. And that's a very important thing to consider. I was one of our gynecology oncologists was giving a presentation recently, and she said the best thing anyone could ever do to reduce their ovarian cancer risk is take 5 years of birth control pills, right? She's like, that is the best thing you could ever do in your life. She's like, we should put it in the water. I was like, well, no, maybe not that, but it does highlight that even things like birth control pills that has estrogen that we know can potentially increase the risk of breast cancer lifetime, right, will significantly reduce the risk of ovarian cancer significantly, and will reduce the risk of endometrial cancer, will reduce the risk of colon cancer. And so it's a balance, right? That, for some patients, if they have a BRCA mutation, then that's a total different conversation, right? Because they have a much different risk profile. You're not only talking about medications, you're talking about potential surgical interventions for those patients. But for patients without genetic risk factors for cancer, I often find just being open and honest about, yes, there is some data that these methods could increase the risk of breast cancer, mostly for estrogen or the higher progestin methods, right? But you have to weigh it with the potential benefits for cancer prevention of other forms. And ultimately, it's a shared decision-making process, right? For one patient, that breast cancer risk is absolutely going to be unacceptable, and they really just, and so then we talk about local methods, right? An IUD, whether hormonal or non-hormonal, is going to give either no hormonal exposure or the absolute minimum we can get, right? The minimum systemic exposure. And so just guiding that conversation based on the concerns. But I think you can't dismiss the potential risks, right? There are risks with these methods, but weighing those with the benefits is always should be part of the conversation. Perfect. Next question. What is the best way to assess patients' risk of blood clots accurately? That's also a great question. So a couple ways. A thorough history and physical, right? I think that is the most accurate means we have nowadays to assess that risk, right? Really emphasizing that it is the patient's personal history of if they've ever had a blood clot, if they've ever had a venous thrombosis in their life, that matters. Family history, something to consider, but unless their family member has been tested and found to have a thrombophilia, the general guideline, the recommendation from the CDC, from the WHO is not to test patients for thrombophilias, because we honestly don't really know if we were to test the entire population, what a positive result would mean. We know factor V Leiden, we know prothrombin gene mutations, those things increase the risk of VTE, but though that's in individuals who have had VTEs, that they've undergone testing and they have a higher prevalence of these clotting disorders. And so that increases the risk of it happening again. We don't really know what happens if you screen everyone. And so that's a question I've had before is why can't I just get screened for these conditions? Well, if it comes back positive and you have no personal history, you have no family history, I don't know what to do with that, right? That I don't know what that really means for your care. So really the personal history of blood clot, the personal history of other risk factors, the obesity, the hypertension, the coexisting conditions, that should guide your assessment of VTE, with the caveat being that the risk, giving an estrogen containing method, giving Depo will always increase that risk. So even someone who has no other risk factors, we should be talking to our patients about that increased risk. And again, a shared decision making. I've had patients who say, absolutely not. I don't want any potential risk for a blood clot, right? Even though I know it's only like 5 out of 100,000 people will get this, that's too high for me. And that's okay. There's nothing wrong with that. And I think that's a conversation we need to have. And, patients want to hear about risks. And I think that's what's caused a lot of this distrust and concern, is that we were dismissive of the risks of these contraceptive methods for so long. We just need to be open and honest about them and share decision making. Make a decision with your patient about what's best for them, while assessing their risk factors and being honest about what we know and what we don't know.
Amazing. Thank you so much, Aaron. Any final tips for shared decision making and that patient-centered care? I think we're seeing, as you said, a lot of misconceptions, concern, also constraints for time when patients coming in with very specific, I want this, I don't want that. And sometimes it's, how do you balance, the time and the counseling? Yeah, just final tips would be super helpful, and they'll wrap up.
Yeah. No, I mean, I'm lucky in that I'm, a subspecialist in complex family planning. So I get more time with my patients to talk about all of these things. In your day-to-day generalist practice of dealing with these issues, it's hard. It's hard to fit all that information into a short conversation. And so that's where things like the Dama Health tool and other, things like that can help, because we can get that information condensed down quickly. We can get the important things out of it to guide the conversation, right? And get to a shared decision-making goal that meets what the patients want in a quick and efficient manner, while utilizing your expertise as a clinician and making sure we utilize that 15-20 minutes to the utmost, right? You could spend that whole 15-20 minutes just talking about their history. And so, there are things like the Dama Health tool that can help expedite that. And so otherwise, listen to your patients. That's also, and ultimately, at the end of the day, don't push things on them. Listen to what their concerns are. That when patients feel heard, that's when they're happiest with their decisions about contraception.
Amazing. Thank you so much. It's a perfect way to wrap up. Thank you so much, Aaron, for your time, and everyone that attended. And we'll upload the webinar as well for those who registered. That will be available after the session today as well.
Right.
And get in touch with us, website, email, it's in the chat. Thank you so much.